right. Good evening, everyone. Welcome to our third session of our CAPER Pancreas Academy series for this year. Today, our session will be on the long-term management of chronic pancreatitis. I'm Sam Han. I'm a therapeutic endoscopist at Mayo Clinic, and I'll be the moderator for today's session. We have two fantastic speakers, the first of which will be Dr. Stephen Hughes. He's a professor and chief of the Surgical Oncology Division at the University of Florida, where he also serves as the vice chair for the Department of Surgery. His NIH-funded research focuses on improving our understanding of the biology of pancreatic cancer and aiming to discover new methods for the diagnosis and personalized treatment of this cancer. He also remains a strong advocate for the surgical management of chronic pancreatitis, and I'm excited to hear his talk about the surgical approaches to chronic pancreatitis. And then our second talk will be by Dr. Anna Evans-Phillips, who's a pancreatologist and assistant professor at the University of Pittsburgh. Her NIH-funded research focuses on using quantitative sensory testing to predict treatment response for pain in patients with chronic pancreatitis. And she'll be talking to us about non-surgical management and pain assessment and management. For housekeeping purposes, I do want to remind everyone that we will have a Q&A session at the conclusion of both talks. So I do ask that you save your questions until the very end. Also, feel free to write your questions through the chat function as well. Without further ado, I'll introduce Dr. Hughes. Take it away, Steve.
All righty, thank you very much. I'm sorry I had a little technical trouble with the presentation I was planning to produce, but I have one here that I think will cover it. Give me 2 seconds and I'll start sharing my slides. Yeah, this will be good. I got a half hour, Sam?
Yep, absolutely.
Okay. So we'll watch the pace here carefully, and if I'm taking too long, then we'll stop at some point. I'm going to share my screen. And then I'm going to go into presentation mode and let me know if it looks okay.
Yeah, that looks good, Steve.
Okay. So welcome, everybody. This was a talk I gave at a retreat hosted by the NIDDK just this last summer, so it's pretty up to date. And the first half of it talks about the current sort of well-accepted surgical approaches to painful chronic pancreatitis, and the second part is about when do you get the surgeon involved?
Actually, Steve, could you, you're kind of in this presentation mode. Could you?
Yeah. You want me to just go to some other mode? Sure.
Yeah.
Let's see. Oh, you can see my notes and all that stuff?
Exactly.
Okay. I wonder if the mode would work. You can still see my screen?
Yeah, I see your whole window.
Okay. No, that's notes. That's no good. Does that work okay?
No, we still see your whole window.
What do you mean by the whole window? Like you can see the things on my desktop, or do you?
Exactly.
All right, well, maybe if I just enlarge it. How's that?
We're still seeing some of the background. Maybe if you go into slideshow mode again. Yep.
I'll tell you what, the problem I run into is I stop share, wait again. All right, now I can share screen and I can pick the one of the two because I'm in a two, which would be this one. How's that?
Better. Yep.
Okay. All right, so full disclosure, I'm not going to talk about a patent I have. I don't get royalties off of it anyway. I do get royalties from a couple of textbooks that I'm an editor on. So I just want to talk about the principles of surgical treatment today. I'm going to really go through given the audience, we're going to talk about the various surgical procedures, and then we're going to talk about the outcomes of surgery for chronic pancreatitis, and then dive into the level of evidence as it compares to endoscopic management. And then finally, if we have time, and I think we will, we'll talk about what we know about when we should go from endoscopy to surgery. And this is the most important point. At the current moment, the role of surgery in chronic pancreatitis is the reduction or elimination of pain. And, caveats of then are that obviously it must be safe. And then there's this hope, and there's some data, but I'm not probably going to have time to get into it, that the notion of surgery, when it's a plumbing problem, draining the main pancreatic duct, may actually preserve endocrine and exocrine function over time. The other thing I want to talk about is I think we really need to think as a society of pancreatologists and pancreatic surgeons about our current recommendations for pain, which start with opioids, and realizing the opioid crisis, maybe that's the wrong thought. And in fact, we should move more towards things like first endoscopy and then, if necessary, on to surgery and save opioids for later. In general, there's 3 concepts of what surgery can do. And it's based predominantly on anatomy, both about is the entire gland involved, that may have some influence based on etiology, or is there a region of the gland that's involved? Are we dealing with large or small duct disease? Are we dealing with a small duct disease where the entire gland's involved? So you see on this slide the 3 key points, and let me know, can you see my little pointer? We can do a Whipple, and it's appropriate in some circumstances. I'll show you that data. We can do a Pusteau or a Fry or what's called a burn, and we'll go through these various operations. Or I think particularly appropriate, especially for children affected with familial pancreatitis, remove the entire gland and I isolate the islets and feed them back into the liver as the current strategy to preserve endocrine function and hopefully solve the problem otherwise. And here this slide kind of recapitulates that and kind of helps you understand that in a large duct situation, we often as surgeons are pretty simple-minded. This is a plumbing problem. I'm going to tell you what Pusteau described is not the operation we do. We do a Partington Rochelle. Fry then kind of improved upon that. In the small duct situation, this shows if there's focal disease in the head, a Whipple or a Beggar or a Fry is similarly maybe reasonable. Or a distal pancreatectomy if you've got a stone or some stricture, perhaps from a single episode of acute pancreatitis, where the tail is struggling and causing symptoms. And then we have this kind of minimal change, in which sense that, and then the entire duct and entire gland and small duct, the TPIT is appropriate. But there's a lot of things to think about as you decide what might be best for a patient that's been referred to you for painful chronic pancreatitis. And they include, are we dealing with a pseudocyst? Is there this typical situation in alcohol-induced pancreatitis with a prominent pancreatic head? Is there a concomitant biliary stricture? Do we have some concern of underlying malignancy? Are there a single stone or multiple stones? How about the duodenum? Is it narrowed? And then even more pertinent for us, it's not infrequent that these patients may have splenoportal venous compromise, and that has huge impacts between resection versus drainage. And then, of course, patient compliance. Are they abstaining from alcohol? And what's their overall performance status and their support? There's some advantages and disadvantages to each approach. Resection is ideal if the concern is an underlying malignancy. Once you do the operation, the complications are not so bad. And to be honest with you, resections can be done minimally invasively, whereas some of the other options are open procedures. There's some data to suggest that resection, because you're reducing parenchyma, that's probably contributing to the endocrine and exocrine functions. that resection is going to actually escalate those problems. Typically because now you're going to have to address the blood vessels, whereas with drainage procedures you don't. You're facing a bigger risk of major intraoperative bleeding, and they're honestly technically more difficult than a drainage procedure. The two options we really have are a Whipple or a distal pancreatectomy when it comes to that, and we've already covered that's really based on, is the disease predominantly in the head or is it predominantly in the tail? And to be honest with you, historically, Whipples have been done for years for people who had diffuse disease with actually reasonably good results, and I'll get to those a little bit later in the talk, including familial pancreatitis. So there's some circumstances where a Whipple procedure, even in small duct disease, is a reasonable option. The distal pancreatectomy comes less frequently, but we certainly see these patients that have some disease process in the body that's leading to upstream plumbing problems. And honestly, the simple solution is to do a minimally invasive distal pancreatectomy. Drainage is obviously superior in patients who have that splenoportal venous compromise. As a whole, they have fewer complications. The operation is a little more straightforward, and they typically go home sooner. It is very much a wrong operation if there's an underlying cancer, and it's limited to patients with a large duct. And here I'm showing the Partington Rochelle. And then here I'm going to show the Fry, where it is basically a Partington Rochelle on steroids, where you also core out the head, and then do a roux limb reconstruction, and then a Beggar procedure, which is still popular in Germany, but virtually not used at all in America. It is a more technically demanding operation because you do have to negotiate the SMV portal, splenoportal confluence. And there's 2 anastomoses instead of 1. And then finally, there's the total pancreatectomy with islet autotransplantation. And clearly, for patients who have not a plumbing problem, but probably a fundamental problem with their acinar cell or ductal cells that are causing the pancreatitis, removing the entire pancreas is going to be the best chance at removing the source of pain, because microscopic plumbing problems are not something that surgery is very good at fixing. And then for folks, particularly, I think it's the PRSS1 or SPINK1 mutations are associated with a lifelong significant risk of malignancy. And so eliminating that risk of malignancy is a benefit of that as well. Now, obviously, they're exocrine insufficient and are dependent upon pancreatic enzyme replacement therapy. For the most part, some do enjoy insulin-free life for a few years, but the islets over time will slowly fail. And so virtually all of them also have to deal with endocrine insufficiency as well. There is expense associated with it. The isolation of islets requires a very special lab and specialized personnel, and you need to have adequate volume to justify offering this option. And in fact, we're a very high volume pancreatic center in Florida, but we don't do this operation. I refer these people out because I would only probably do 6 of these a year, and you just can't justify that islet isolation lab with that kind of small volume. If you look across the panel, and I want to give my thanks to Kevin Behrens. I stole this table from him with his blessing. If you look at the various benefits of the operations, it's interesting that the majority of patients actually become narcotic-free within 6 months and enjoy an improvement in their overall quality of life. The operations aren't particularly different with respect to mortality or morbidity, although surprisingly, the biggest risk of drainage and resection is a pancreatic fistula, which is not a component of TPIT, and yet it has the highest morbidity with complication rates and the highest incidence of reoperation and readmission. But this is all around the complexity of managing their blood sugars. So let's go into some data. And this is kind of a seminal paper that was published in 2007, Marco Bruno from the Dutch Pancreatitis and Pancreatic Cancer Study Groups. They have contributed dramatically to this literature, and you're going to see more than just one paper from them. They took 118 patients eligible for this consideration, excluded 79. So they were being a little picky about who they picked, but they only had to randomize 40. And 20 of them underwent endoscopic drainage. Actually, 3/4 of them had lithotripsy and other efforts to reduce their stone burden. These were all patients, by the way, with large duct disease. And then would undergo endoscopic ERCP with stone extraction and stenting. And then 20 went straight to surgical drainage, and they were picking patients who had low opioid requirements. And I'll cut right to the chase here. From a pain relief perspective, surgery was superior, with 75% saying that they had significant improvement in their pain. Only 40% had complete relief, 35% partial, and 25 none, as opposed to 70% that did not have relief after endoscopy. But I want to tell you that if you dive into this, these 3 patients that had complete relief, the endoscopist made a comment that they were able to completely clear the duct and had free drainage, where these others, there were technical challenges in completely clearing the duct of either strictures or stones. The complication rates were relatively similar, and certainly didn't reach significance. And the number of procedures was considerably higher endoscopy, with a number of 8 versus surgery of 3, too many. But fair enough, 3 of those 8 procedures were diagnostic and 5 were therapeutic, whereas in the surgical arm, typically they had gone through a couple of endoscopic procedures and then had 1 therapeutic procedure. The quality of life in the surgical arm, interestingly, was a little bit superior. This is a summary of a number of papers. It was this one other one, and then one from Bill Nealon. And to cut to the chase, they basically showed the same conclusion, which is that surgery works for chronic pancreatitis. I'm going to show you a little bit. This is a question about resection versus drainage. This is kind of that classic thing I was just telling you about, how some folks will get a Whipple versus a drainage procedure. And there were some single center studies that would suggest that a drainage procedure was superior. And I'll cut to the chase here. A large multi-center trial with 250 patients. And when they looked at quality of life before and after, the multi-center study did not show that drainage was superior and that Whipple was equally adequate. And the argument about this paper is that it's a lot easier to find a surgeon at a center who's capable of doing a Whipple than it is to find a surgeon who's comfortable with the resection or with the drainage procedure. I wanted to point this out, though. So in this entire study, they excluded patients that we thought were going to have cancer. And interestingly, 5% of them in their final pathology did, in fact, actually have a malignancy in their final specimen, which is a devastating situation in the drainage group. We don't have comparative data with TPIT. What we have are single studies, and Melina Beelan and the Minnesota group had this wonderful paper talking about their experience at Minnesota, almost 600 patients. And what they came to realize was that, and this gets kind of important, it'll become a theme, that the results factors associated with narcotic use after this was early sphincterotomy or greater than 3 previous stents, persistent pain, a larger BMI, etiology of alcohol, I want to point out here, greater than 5 years that came up. But interestingly, in their experience, and it's not fair because they were doing a lot of children where you don't want to rush to the operating room, the duration of symptoms of chronic pancreatitis prior to surgical intervention was 7 years. And that's an important thing to consider as we talk about some data I'm going to show you in a little bit. What's really nice is that they now have this post-trial funded and a nice series of folks who are doing large numbers of TPIT, and they're in the process of accruing 450 patients. And it's really a descriptive study without planned interventions, but I think they'll be able to actually come up with some plans to intervene in different ways, including timing, once they gather all this information. This is the first paper that came out of POST, just kind of describing a few things that are interesting, which is that children are more likely to wind up with a splenectomy, pylorus preservation, a roux reconstruction, more likely with a J-tube, islet yield, hospital stay. But it's a very nice paper, and I highly encourage you to take a look at it. This was a very important study also from that group, which is really important for you all and for surgeons if they're on the call, which is that there is no reason to not approach a chronic pancreatitic with pain with endoscopy first. It has no impact on islet yield, and we're going to talk a little bit more about it. It has no impact on subsequent success of surgery. So endoscopies first is going to be one of the things we're going to talk about. Sorry. Oh my goodness. Those are my dogs. Now we're going to share a little bit more data about are we operating too late for painful pancreatitis? And I think this gets into the timing concept. Here's a paper, once again, from the Dutch study group, where they were looking at what were the clinical factors that were associated with success versus failure with surgery. And what was interesting is that a couple of things fell out in a multivariate analysis as independently predictive. And these are important. If you've had chronic daily pain for greater than 3 years, it has a significant impact on the likelihood of pain, surgery being successful or not. And of course, that's associated with preoperative opioids, but yet it's set out by itself. If they're not on daily opioids when they come to surgery, it's worth 7 points on this nomogram. And then there was this magic number of 5 endoscopic interventions, which was even more important. And what you get down to is that if you get there, with fewer than 5 endoscopic interventions within 3 years, when people were probably having relapsing acute pancreatitis with imaging features of chronic pancreatitis, but not with daily pain, that you had a 75% of surgery making you narcotic free within 6 months. This study was well done. They had significant follow-up of 62 months. But sadly, there was obviously a lot of heterogeneity in the overall results, with some, only a fourth to up to 75% of folks actually really enjoying benefit. This is a separate study that followed shortly thereafter out of the Beth Israel group, and they took a look at a fairly sizable number of patients. And interestingly, I'm going to kind of skip a little bit through this for the sake of time and because it's kind of reiterative. What they demonstrated was a time point of 26.5 months. So kind of in that 3-year time frame once again. And then this paper was published in 2018, suggesting that the earlier you go to surgery, you're going to improve outcomes from chronic pancreatitis. And then this is the ESCAPE trial that we really want to focus on as well. This was early surgery versus endoscopy, and there's a couple of key points that come out from this. I think just kind of general themes that the literature keeps coming back to. This is a very well-controlled study. What they were looking at were these folks that were very early in their disease, so less than 6 months of what they referred to as weak opioids, like tramadol, hydrocodone, acordine, or less than 2 months of strong opioids. They didn't allow folks with previous pancreatic surgery, contraindications for ER superior surgery, biliary obstruction was excluded, or of course this concern for malignancy. And so they randomized 88 patients either into early surgery versus endoscopy first. And here's the Izicki pain score, which was their endpoint, demonstrating that the endoscopy first did not do as well on the Izicki pain score with respect to relief of pain. This graph is a little hard to follow, but if you pay attention, there's this little bit of missing data. there's a sizable amount of this light blue, which is minimum to no relief, and then a slice of this partial relief, and then there's complete relief. And what you see is that the early surgery folks hit this complete relief within about 4 months, and then they kind of plateau. And interestingly, in the endoscopy first, you see it plateau a little bit later here. And the explanation that the authors provided is that 60% of the folks who had endoscopy first crossed over to the surgery arm, but were analyzed in an intent to treat fashion. And so they attribute this second spike in folks who crossed over to surgery. And the important key point there is that early surgery actually is, you need to get there early, not after the pancreas is burned out. And I'm going to show you one other concept about why I think that matters. I didn't share all this data, but surgery was associated with a lower number of total procedures, that there is a high crossover from endoscopy to surgery, which I think is just fine. As I've said, I think endoscopy first is the right thing to do. Buried in the data was that if you cross over within that magic 2 to 3 year time frame, surgery will still work. But also the really important thing, especially for surgeons, because a lot of them think, well, if you put a PD stent in and it didn't work, then surgery's not going to work. But that's not true. Failure of endoscopic therapy did not necessarily impact success with surgery. And some of that, I think, is going to be subtle and take larger studies. And it gets down to that earlier concept I talked about, where if you could clearly clear the duct of all stones and not have a problem with strictures that weren't manageable with stenting, endoscopy alone was very successful. Surgery can overcome those barriers by opening up the entire duct and exposing all of that to better drainage. So that's probably the main reason that endoscopy can fail and surgery can succeed. This is a concept that I think is important about the 3 years, and it's this notion of the development of a hyperesthesia syndrome. And I'm sure Dr. Evans Phillips is in a much better position to talk about this than me. She is the second author. But this is a really interesting component of chronic pancreatitis, which is that what they've demonstrated very nice is that it's a heterogeneous group of patients who have chronic painful pancreatitis. And there's some by their testing that have no hyperalgesia. There's some where it's just really kind of in the region of the abdomen. And then there's folks that actually can develop it widespread. So their fingers and their toes and their head hurt. And perhaps that's opioid dependence. But it's fascinating data. Unfortunately, this paper, I don't think, and Anna, please, when you give your talk, it didn't look at the time that these patients had pain. And the final thing I'm going to talk about here is that, well, surgery for chronic pancreatitis works. We're not doing it very much. In fact, the number of operations for chronic pancreatitis is in decline. This is unpublished data from the National Surgery Quality Improvement Project, looking at the total number of cases of pancreatic surgery and the percent were done for chronic pancreatitis. And even in the last 10 years, surgery for chronic pancreatitis is almost going extinct. And with that, you want me to answer questions now, or I can reiterate these conclusions. Surgery works, it reduces pain, improves quality of life. I didn't get into the details because I don't think we have randomized data that's well controlled, but there's some hints that it might actually preserve exocrine and endocrine function. If you look in the early setting, surgery outcomes are superior to pancreatic duct stenting, but now I'll just leave it at that. I think we operate too late and too infrequently for relapsing acute and chronic pancreatitis. That's my summary. Thanks for your attention.
Thank you, Steve, for that fantastic talk. And we're going to reserve questions until the end of Anna's talk.
Okay. Sorry about the dogs barking in the middle.
No worries. All right.
I'll stop sharing my screen here.
Thank you, Steve.
If I can figure out how.
Thank you, Steve, for that great talk. That's really fantastic. And I think it highlights so much of what we are trying to do to treat this very difficult patient population. And so, to the audience members, thank you so much. I see some of the questions already in the chat, and so please feel free to keep them coming. We can parse them out between Steve and myself at the end of this, and I'll try and keep this short to give a few minutes for actual discussion and so forth, since there's a lot of gray area here. My task, I'm Anna Evans Phillips. I'm a medical pancreatologist at the University of Pittsburgh. And so I'm tasked with talking about non-surgical management of painful chronic pancreatitis. And in addition to a couple of non-financial disclosures, again, I'm a medical pancreatologist. And so the main thing that I would highlight here for an audience that is learning about pancreatitis is to underline very carefully that we have no drug treatment and no cure for chronic pancreatitis. And so this is a disease in which there's a lot of work to do. And I think at the current time, our main task is to support patients who have this diagnosis and try and treat and avoid complications. So just by way of orientation to this talk, I'm first going to talk a little bit about pathophysiology and complications, then evaluation of the disease, and then treatment to include medical and endoscopic. But then surgical has already been covered in great detail, actually, by Steve. Thanks so much. And so the definition of chronic pancreatitis is something that has long been a bit controversial, but there is much consensus now around the definition of a disease that is a fibroinflammatory one of the pancreas that is the result of inflammation. It does not heal, it does not improve, and it represents permanent damage to the gland. In up to 90% of patients, it manifests with chronic pain, which is quite debilitating for many patients, at least at some point during their disease process. And in some subset of patients, also manifests with the inability of the pancreas to then subsequently make digestive enzymes, phenomenon called exocrine pancreatic insufficiency, or hormones such as insulin, glucagon, and other regulatory hormones, a phenomenon called diabetes. Type 3C is what we see in end-stage chronic pancreatitis. So pain in chronic pancreatitis, again, most disabling symptom of the disease. It is the thing that drives patients to healthcare, affects up to 90% of patients over the course of their disease, and there's a lot of stigma associated with it. Many patients have had alcohol etiology of their disease, and to this day, they experience a lot of stigma actually when they present to the emergency department or are admitted to the hospital with pain episodes associated with their disease. Painful pancreatitis is not treated in the same manner as other painful abdominal conditions, including inflammatory bowel disease or peptic ulcer disease. Again, we have no direct treatment for this and no cure. And so invasive therapy is offered to patients whose pain is thought to be due to obstructive disease, where they may have stones in the main pancreatic duct or strictures. However, pain response to invasive treatment is oftentimes unpredictable. And there are multiple theories as to why that's the case. Some of the older theories about this, can be seen in this diagram from a Pancreapedia article from a few years ago now, but this can be related to either a plumbing versus a wiring problem, broadly speaking. And so wiring problems might refer to things like neuropathic pain, sensitization of the peripheral nerve system, neuropathy, central nervous system changes, which we'll get into a little bit more later. And then, other things, including things like inflammatory masses, pseudocysts, duct stenoses and stones, et cetera, can all contribute to the pain experience that patients have. An unfortunate fact is that clinical pain symptoms correlate extremely poorly with pancreatic ductal morphology on imaging findings. And so quite frequently what we see is that patients' pancreases may look quite dramatic on imaging, coarse calcifications, severe glandular atrophy, and yet they may be having very few symptoms and be able to live a productive daily life. However, other patients may have fairly mild findings on imaging but find their symptoms quite debilitating. And so there have been numerous attempts, some of which Steve had kindly outlined, to try and define other characteristics that correlate with pain. Now, classically, pain patterns in chronic pancreatitis have been broadly divided into two types of pain. Those would be type A pain, where patients have episodes of pain, but long, sometimes pain-free intervals for years, months or years. And then in type B pain, patients may have a more chronic daily pain with then exacerbations of pain over time. There's also a theory that patients, over time can develop burnout of the pancreas, and that's been somewhat controversial just because it's not clear that that is a phenomenon shared by, certainly not by a majority of patients. And so it's something that, is observed in a subset of patients who might experience such. Instead of pain being static, however, one of the important concepts that has come to light in recent years, again from our colleagues in the Dutch Pancreatitis Study Group, has been that pain is actually a very dynamic phenomenon for patients. And so in this study, where a Sankey diagram was created to illustrate this in an extremely elegant fashion, you see that in this cohort of over 1,000 patients with definite chronic pancreatitis who were followed up over almost 4 years, almost 2/3 of patients had at least one change in their pain profile over that time. And so again, pain for this patient population is dynamic, and that makes it a moving target. As Steve also alluded to, the overlapping contributors to the pain experience in this patient population mean that this phenomenon becomes more and more complex for patients over time. In this study that our group published in 2021, you can see over on the left-hand side, what we did was assess multiple different factors contributing to the pain experience individually. Those included pancreatic duct obstruction, hyperalgesia as assessed by quantitative sensory testing for these patients, and then psychologic distress, which was a variable that encompassed symptoms of anxiety, depression, or catastrophizing. And so on the left here, you see a Venn diagram of the overlap of these factors in a cross-sectional study looking at patients with painful chronic pancreatitis. And on the right, what you see is the linear increase in both pain severity and pain interference, as well as the linear decrease in quality of life with the accumulation of each of these individual pain-related factors over time. Through no surprise, patients with chronic pancreatitis and psychiatric comorbidity clearly have lower quality of life, and this separate publication illustrated that very clearly. In red, you see the outline for scores in the European Organization for the Research and Treatment of Cancer Quality of Life questionnaire. Patients with either anxiety or depression and chronic pancreatitis scored across the board in lower quality of life in all of the tested domains. The same was seen in patients with symptoms of depression as compared to their counterparts with no depressive symptoms. Now, the prevalence of anxiety and depression in patients with chronic pancreatitis is high, and it bears mentioning because this is a comorbid condition that I think is something that can often be assumed is present, but is really important to assess and potentially treat as a comorbid condition, as opposed to making assumptions about it as patients come in for treatment. And so in this publication, again from a few years ago, we were able to put some numbers to this phenomenon, and we saw that almost half of patients have symptoms of anxiety, over a third have symptoms of depression, and then almost a third have overlap symptoms of both. And patients who have anxiety or depression were seen to be more likely to report pain to begin with, report pain of higher severity, and more pain interference with their daily life. And so this outlines the way that I would think about a management strategy, a medical management strategy, if you were, for patients with painful chronic pancreatitis. And you can see here that it encompasses referrals to other types of providers, including therapeutic endoscopists and surgeons. And so I'll be eager for additional discussion at the end about how they might think of these things. But first and foremost, a comprehensive pain assessment for these patients is extremely important. Understanding what the triggers are for their pain, what it affects, the bounds of their pain, and the duration, as well as how it affects the rest of their life, is incredibly important. And so we'll talk about an emerging tool that is available for use to do just that in a moment. I would always evaluate for concomitant conditions. So anxiety, depression, insomnia, nutritional deficiencies, other complications, including endocrine and exocrine insufficiency. All of these things are really important elements in the assessment and treatment of painful chronic pancreatitis. The analgesic ladder, was discussed briefly by Steve, and I'll illustrate that in just a moment. Patients often climb the analgesic ladder all too quickly in the U.S., as about half of patients with chronic pancreatitis are maintained on long-term opioids. That's not counting the patients who are treated with short courses of opioids, over the course of initial evaluation and workup. And so this is, although it's a foundational therapy here in the US, something to think about, especially with potential alternatives. Adjunctive therapies, including things like additional psychotropic medications or neuroactive medications, are things that I would generally consider, especially as modifiers for opioid use. And then concomitant to all of this, within the comprehensive pain assessment and evaluation for concomitant conditions, I would certainly evaluate for and address obstruction of the pancreatic duct as something that may be an intervenable target early on in my assessment and treatment of that patient. Consideration then of invasive therapy for either therapeutic endoscopy or surgical therapy to relieve ductal obstruction is an important step. Next, I think consideration of surgical therapy for things like total pancreatectomy, if a patient may be a considered candidate, is an important thing to also put on the table. Last but not least, not only is pain a moving target for treatment, but I would say there have been more and more advances and a lot of work put into treatment options for patients with painful chronic pancreatitis. And so I think consideration of clinical trials for patients who may be eligible candidates and those who are willing to participate is something that I will often offer to my patients as a way to participate in cutting edge research. And so going back for just a moment into the assessment of chronic pancreatitis pain, this is a table from a few years ago now, but I placed it here to highlight for the audience the fact that up until very recently, we've had a number of tools to be able to try and assess chronic pancreatitis pain. You see the names of many of those tools across the top of this chart. And over on the left-hand side, what you see are aspects of pain in chronic pancreatitis. What you'll notice very quickly, just with a glance, is that there are many domains of pain that are not addressed by many of the pain assessment tools. In particular, you might notice that postprandial pain, one of the hallmark features actually of painful chronic pancreatitis, is something that's not assessed by any of these tools. And so I think the message here is just that we have been really lacking until recently an adequate tool to assess in a disease-specific fashion the pain phenomenon that these patients are experiencing. And so recent publication actually in 2021 of the comprehensive pain assessment tool for chronic pancreatitis, the COMPAT short form. It's a 3-page questionnaire that is published in Clinical Gastroenterology and Hepatology and is available for use in both the clinical and research realms. This is something that I think is being disseminated widely for use as an outcome in research studies, and it's something that I think can serve as a very valuable tool for providers for patients with painful chronic pancreatitis to better understand what's going on with their patients. Now, with regard to medical treatment for painful chronic pancreatitis, as I mentioned, the analgesic ladder, one that is adapted for chronic pancreatitis from the World Health Organization's treatment for chronic pain for cancer, is seen on the right here. And so usually patients are starting with non-opioid analgesics and again climb perhaps all too quickly, up the ladder to potent opioids and then essentially evaluation for invasive therapies if they are candidates. And I think to Steve's point, there is good reason to consider those things in the opposite order if it's at all possible. Oftentimes patients have been maintained on opioid analgesia for a long time before that's even considered. And so we're hoping for a change in that in the years to come. Foundationally, you'll see in the ladder diagram, actually, abstinence from alcohol and tobacco cannot be stressed enough. For patients for whom this is an etiological consideration, it is very important, of course, not to subject them to additional stigma. However, removal of both tobacco and alcohol from the picture can make a world of difference, both in their perception of pain, as prior research has shown to us, but also in the therefore stoppage of progression of the disease over time. Medical treatments might also encompass adjuvant therapies, as we'll talk about again in just a moment. This table was recently published actually just earlier this year in Pancreatology, and this highlights the frequency with which neuroactive and psychotropic medications are used in a cross-sectional cohort of patients with chronic pancreatitis. And I highlight this just because many of these medications are not adequately researched in terms of their effect in chronic pancreatitis in either treating comorbid conditions, anxiety, depression, insomnia, etc., or in their efficacy at relieving or altering their pain experience. And so I think this highlights for us the fact that many providers are already using these medications, but it will behoove us to understand this phenomenon better in coming years. And so we hope to be doing research in this area to understand more about how these things can be beneficial to certain patient populations. And so here, I would put forward the import of targeted management of identified comorbid disorders as an important part of medical management of these patients. So for psychiatric therapies, concomitant disorders as previously described, anxiety, depression, etc. Cognitive behavioral therapy is shown to be both feasible and acceptable in patients with chronic pancreatitis. And so for those patients who are open to this as an adjunctive therapy, an important aspect of treatment certainly to be able to offer to them. Sleep aids for patients with insomnia are very important. It's been increasingly shown actually that patients with chronic pancreatitis suffer out of proportion to the general population with insomnia. And this is something that can exacerbate the perception of pain as well as comorbid disorders of anxiety and depression. Pancreatic enzyme replacement therapy, or PERT, as you probably heard it called, for treatment of pancreatic exocrine insufficiency is a very important part of treatment, and that's a topic for another talk, of course, but an important part of also relieving any abdominal pain or gaseous distension that might be occurring comorbid to the chronic pancreatitis itself. GABAergic medications, including pregabalin and gabapentin, should be considered. The research that we have to date is mainly in pregabalin, which does show a decrease in symptoms of pain, at least short term, in patients with chronic pancreatitis. These medications aren't without side effect profiles, and so important to consider, and certainly, remove them from the treatment group if that is a problem, but important to consider. SNRI and SSRI medications can be useful both for visceral hyperalgesia as well as symptoms of anxiety and depression. And then consideration of nerve blocks as well can be an important part of therapy in certain patients who may benefit from such. Now here, as not a therapeutic endoscopist, I won't go into this in great detail, but I will say that endoscopic treatment for painful chronic pancreatitis, as Steve mentioned, is an important part of therapy, at least to consider. Many patients are quite hesitant to undergo surgery, despite the research that we have that shows that in the right, carefully selected patient populations, it can be of great benefit. And so one option that is considered and often offered to patients include two modalities that may be used in conjunction or independently, and those include extracorporeal shockwave lithotripsy, which helps to break calcified stones that may be obstructing the main pancreatic duct, and endoscopic retrograde cholangiopancreatography, or ERCP, in which endoscopically stones can be removed, strictures can be dilated, oftentimes stents can be placed in order to relieve obstruction of the main pancreatic duct. Surgical treatment has been covered by Stephen, again, wonderful detail. And so here, this is just to highlight the fact actually that even as a medical pancreatologist, close collaboration with my surgical colleagues locally is incredibly important and really an essential part of my practice in order to make sure that those patients who are good candidates for this get the treatment that they need. As he also mentioned, pain response rate to treatment, however, is suboptimal. And so there are clearly parts of the pain experience that we still do not understand. And so to this end, I think maybe this slide hadn't gotten shown in the recent ESCAPE trial, but I like this slide and this particular figure just because over on the right-hand side, what you see is that there is a pain response to treatment in both the surgical and endoscopic groups, but once the ductal clearance is achieved, the rates are similar between groups. The important thing from my perspective, though, is not to raise that age-old debate, but rather to highlight the fact that patients still, despite all of the therapies offered, medical, surgical, and endoscopic, on average still had pain at the end of this. And so I think together we are still missing something that is an essential element of this experience. And so here for the group, I'll just highlight briefly the concepts of pain versus nociception. Pain having both a subjective and emotional aspect that can be associated with actual or potential damage. Whereas nociception is specifically the response of the sensory nervous system to either harmful or potentially harmful stimuli. And so here, this difference is important because we spend a lot of time thinking about biomarkers for pain. However, a true biomarker for pain to measure that response is unlikely to be successful given that emotional experience component. However, biomarkers for nociception may be possible. And so here enters the concept of central sensitization. The paper that Steve had mentioned from a few years ago looks at this phenomenon in patients with painful chronic pancreatitis. And so this refers to the amplification of neural signaling within the central nervous system that elicits a pain hypersensitivity. This is known to accompany the pain experience in many patients with chronic pain from all different types of etiologies. And so this is in its early stages of investigation in chronic pancreatitis. There is no clinical test to identify this to date and no treatment for it either. And so while it is important, we still have a lot of work to do to effectively address this problem even when identified. This schematic identifies actually our thought process about how this may develop in chronic pancreatitis, where over time with recurrent attacks of acute pancreatitis on top of existing chronic changes in both the peripheral nervous system and then subsequently in the central nervous system can lead to an altered pain perception through altered nociception and subsequently the phenomenon of central sensitization that becomes comorbid. And so again, I'll highlight, the management strategy here, just in list again to mention that this is a complex, individualized treatment plan for every patient that walks in the door, but there are important aspects to it in all cases. And so these are the things that I would, again, consider from a medical perspective. There are many future directions that we can take this, and this will be the content of our discussion to come. And so with that, I'd like to thank the following individuals, and I will stop there. Thank you so much.
Thanks so much, Anna, for that wonderful presentation. Steve, if you could join us well. We'll start the Q&A session. I do want to start off with the first question from the chat, which is from Ashley Polachek, about whether there's a potential option for retransplantation of islets, potentially with interventional radiology, after they fail over the first few years. Steve, maybe you can take a stab at this one.
Yeah, intriguing notion. These islets are pretty fragile. I think to do what they're suggesting, you would have to freeze down a sample of them, which may compromise the initial effect and the likelihood that the thaw and reimplementation would be successful. It's an intriguing notion. I can see a lot of reasons why it might not work, but it's not out of the question. And then I'll get out of my skis like a surgeon does. Islets are intrinsically, I think, immunogenic. And this failure, I think, to some degree, is we're putting them in a wrong spot. It's pretty amazing that they implant in the portal circulation. But what we're seeing in TPIT or with longitudinal studies is that their insulin production wanes with time, and you can't go look to see what the islet mass is, but it would suggest that perhaps there is an autoimmune elimination of those successfully transplanted islets. What do you think, Anna?
Certainly, I think that's possible. I think the short answer I would say right now is no. Unfortunately, there's not really an option. At the current time, patients need all the islets they have in order to optimally manage their blood glucose homeostasis. And so, as Steve mentioned, I think trying to divide that over time would create probably a suboptimal outcome that I think wouldn't be ideal for the patient either.
Great question.
Great. I'll open up the forum for any other questions from the audience. While we wait, though, and as you were speaking, I couldn't be struck by the notion that, there's so many kind of comorbid conditions related to pain. You mentioned, the psychiatric comorbidities, and it emphasizes the need for a multidisciplinary team for pain management. And the reality, though, is for a lot of people who are on the call, probably, these centers don't really offer those kind of multidisciplinary clinics, especially for chronic pancreatitis. But in your ideal world, what kind of disciplines do you think would need to be involved for optimal pain management?
Great question. The truth is that chronic pancreatitis remains a rare disease. And so, to this end, it's really necessary to have collaborations between expert centers, just because otherwise, it's hard to move the needle forward in terms of progress. Ideally, I think, a medical home idea for patients with chronic pancreatitis would include nutrition, pain management, and psychiatry, at a minimum. In addition to that, a pancreatologist that can also understand and be able to take action on imaging abnormalities whenever is necessary, I think is really important. And so that's what I would, think as a beginning group, with, of course, the hopeful participation of therapeutic endoscopy and surgery, since those are such essential parts of treatment for the disease.
Yeah, no, absolutely. Steve, would you have anything to add on to that?
No, I think she's covered it perfectly.
Yeah, I think my only other comment would be maybe also including, if they smoke or drink alcohol, maybe including like smoking cessation specialists or, alcohol cessation specialists as well. Especially smoking, I think, is so highly prevalent in chronic pancreatitis. So I think that's something that, as like a gastroenterologist myself, I really had no expertise in smoking cessation. And so it's tough for me to kind of manage something like that.
But Sam, you bring up a really important point that I want to cover, which is that alcoholism is a disease. Unfortunately, the treatment is abstinence, and to get people abstinent takes an intense commitment on their part and on the medical community. But when they are in the hospital with pancreatitis, it's the time to strike, but very few clinicians do so. They manage the pancreatitis, but they don't manage the alcoholism because it's hard, and you can't do it in that acute hospital stay. But you can set up the patient for the notion that, we're not just going to send you home. So introduce the notion of inpatient rehabilitation or participation in some of the alcohol cessation programs like Alcoholics Anonymous, and don't be what do I want to say? Treat them with respect and treat them as if they have a disease. And I try very hard to do that in the patients that I interact with. And they're rather motivated to not ever drink again when they're in the hospital with pancreatitis. It's a really good time to strike, but you can't just send them home and say, hey, yeah, just don't drink. I don't think that's fair, right? And I would be very interested in us trying harder as a medical community to kind of appreciate the fact that this is a disease with a treatment, and that we need to prescribe that treatment while they're in the hospital with their episode of acute pancreatitis for their alcoholism.
That's a great point. There's a question from the audience from Victoria Vasquez about, are the levels of pain or type of pain associated with the etiology of the chronic pancreatitis? Anna, do you want to address that?
Sure. There's a lot of nuance that's built into that question. And what I can say is that initial classification of pain into types A and type B was actually all done in patients with alcohol-related pancreatitis. And so what I would also say, to follow that on with, is that that's a relatively antiquated notion at this point in time. I think we know a lot more about multiple etiologies of chronic pancreatitis, and so it's something we can no longer make any assumptions about at this point. The more recent study from the Dutch pancreatitis study group, which showed the Sankey diagram actually about the pain pattern in patients, is all comers. And so still alcohol remains a very common etiology of chronic calcific pancreatitis. But I would say that, the etiology is not the sole contributor to what the pain experience is.
Gotcha. Well, thank you. The next question is about chronic pancreatitis in children not exposed to alcohol or smoking, and I guess what the management would entail for those pediatric patients.
I can jump
Let me
into
just
this
say
a
first.
little bit. Oh, go ahead, Steve. Yeah, you go ahead.
I think the most important thing is a genetic assessment in a child with pancreatitis, to understand if it is indeed familial. And then depending on the gene, with the right knowledge, you'll have a better understanding about the natural history of the disease. I think we're learning a little bit more about the CFTR gene mutations and the natural history of that disease, which I think is different than the trypsin mutations or the SPINK1 mutations. The tropical pancreatitis, which has now been shown to be genetic in nature, is a terrible form of the disease. We fortunately don't see much of it in America, but when you do, the diabetes, the pain are intense. We know most about PRSS1, and thank you, David Whitcomb. The risk lifetime of cancer in those patients is very real. So at the end of the day, if you have a child with pancreatitis, the other etiologies become unlikely but need to be considered. And I think the focus should be on genetic assessment. And if in fact they have an underlying genetic etiology of their pancreatitis, unfortunately, the natural history of that disease over their lifespan is probably going to lead to some sort of operative intervention.
Anna, did you want to share your thoughts as well about?
No, I think that was perfectly put, actually. It's a great summary of it.
Great. Any other questions from the audience? While we wait, I was struck by something that Steve said in terms of the timing of surgery and endoscopy for that matter. And I wanted to get a sense of, we were talking about multidisciplinary management, and as a surgeon, Steve, when do you want to meet the patient essentially as soon as they're diagnosed with chronic pancreatitis, or do you want to meet them after they're having kind of persistent pain, or when do you think is the optimal time for surgeons to even get established in terms of the care of these patients?
Okay, so I want you all to kind of put a subtle sort of buffer on this. Surgeons typically get referred a patient who has lost their job, lost their family, lost their insurance, and is on 60 milligrams or more of morphine a day, and now they're asked to fix their pain. That's not the right time. It's got to be sooner than that. When you've run out of all options and you just can't. This patient's on your hospital service and constantly. That's way too late. I think Anna's really shown nicely. She talked about the type A and type B of pain, and Dr. Yadav also has kind of demonstrated that most of these folks that have painful pancreatitis go through a relapsing acute episodes and then ultimately have daily pain. And my ideal would be when they have had 3 episodes leading to hospitalization within 6 to 12 months, or if it's markedly disrupting their life, right? So they're at risk of losing their job. When their disease is really starting to compromise their life, it's time to start to really escalate. The notion of endoscopic therapy, like I said first, in appropriate patients, and then surgery in others. I think endoscopy and surgery have a lot in common, with the exception of the resections or the TPIT. In the large duct disease, certainly endoscopy first. and then save the drainage procedure, barring some concern of malignancy after endoscopy. And some folks hopefully will never come to surgery. For the small duct disease, hopefully it's focal and you can do a partial pancreatectomy with great results. Or if it's genetically driven or involving the entire gland, then I think the notion of referring them to a TPIT center is the right thing to do before they develop this central pain syndrome. But I'd be very curious about, Anna, do you think this is something that this timing that I talked about, this just makes sense to me, is that if they're in pain, and by the way, pain drives people nuts. So the anxiety and the depression, it makes sense to me, right? I think the pain precedes those other diagnoses, to be honest with you.
I mean, we've even shown previously that when both pain and hyperalgesia are present, the presence of psychiatric comorbidity is common. If you take away the pain, the psychiatric comorbidity goes away. The hyperalgesia may stay, but it's of little consequence at that point, given that the pain is gone. And so I would absolutely echo that. I think consideration for intervention, especially surgical intervention, is frequently done when the window has already closed. And that is unfortunate for so many patients. And so I think it's something that needs to be considered, I would say on average, earlier than has been done. I know in my practice, it's a conversation that I start with patients often at the time that we meet in order to give them an idea of what the spectrum of treatment options at the current time looks like.
Yeah, that makes a lot of sense. And I think another thing that we are taking for granted, however, in our conversation is that, you need to have surgeons who are capable of doing drainage procedures.
Mm-hmm.
And I think if anything, this is kind of a urging for young surgeons or surgeons in training to really also consider a career where they do pursue this and not just, resection procedures within the pancreas, which have kind of become the popular thing to do nationwide. And so I think, yeah, there just needs to be continued emphasis on maintaining these kind of high-level procedures.
Totally agree. But if all they get to operate on are people with centralized pain syndromes and no insurance, it's going to be hard to grow a cohort that's capable. So,
Yeah.
I mean, we're going to have to do it in parallel and work together on it. And hopefully we'll find some solutions other than surgery. I mean, my entire research effort is to try to avoid operations on people. So it's kind of interesting that I'm trying to put myself out of work. But I'd be delighted if I didn't have to operate on a pancreatitic. But we do have a good therapy, but we got to get there in time.
Yeah, absolutely. Well, if there are no other questions from the audience, then I think this concludes a terrific session. And I really want to thank our two speakers, Dr. Phillips and Dr. Hughes, for participating today. And yeah, thank you everyone for joining. And this wraps up our third session of the Pancreas Academy series.
Thank you so much.
Good to see everybody.